Okay, everyone, so I'm going to get started. My name is Rebecca Kronman. I go by she and her, and I'm speaking to you from Lenape Territory, Brooklyn, New York, where I'm a clinician in private practice. The focus of my practice is in psychedelic harm reduction and integration, and I'm also a CAP therapist. I work with a prescribing partner, which is Journey Clinical, and I do a little bit of training for them. I'm also a trainer with Fluence, where I teach a class. Usually I teach a class called CAP Theory and Methodology. And a few years ago, I began a group called Plant Parenthood. And we explore the intersection between family and psychedelics. And we do that by holding safe and supportive community space for integration circles. And we also do that by hosting educational events. So I'm very excited to be here today. This is the first time that I've done something as part of Plant Parenthood and also as part of Fluence. This is Fluence's monthly webinar. And so they host these for free each month, and you can sign up. Each of you will be receiving a recording after this session. So I want to take a few moments to just go over the structure of today. So I'm going to have a chat with Melissa, who I'm going to introduce properly in just a moment. And we'll take about 15 minutes at the end of the webinar to answer your questions. So I would love to ask you, if you have questions as we go along, could you please use the Q&A feature? And that allows us to keep track of which questions that we've answered. So Q&A feature as opposed to the chat. We'll do our best to monitor the chat as well. I want to just talk for a moment about language here. So not everyone who has a pregnancy identifies as a woman. Not everybody who breastfeeds or chest feeds identifies as a woman. So we're going to do our best to use gender neutral language today and talk about postpartum bodies, breastfeeding and chest feeding. And sometimes that language gets a little bit clunky, and sometimes our words that we're more accustomed to slip out. So we're just asking for your grace and your patience as we kind of navigate this linguistic terrain. So I was first introduced to Melissa's work several years ago when she published a study about ketamine and breastfeeding and chest feeding. And I have to say, this is probably the most common question that we get asked about at Plant Parenthood, is about the impacts of psychedelics on a breastfeeding, chest feeding person for their newborn. And so I've sent Melissa's paper to so many people to review, because it's one of the only studies that's published about this topic. It might be the only one thus far. And so we're going to talk a little bit more later about that paper specifically, but in general, this topic, and more broadly, the topic of pregnant and postpartum health, is one of the most underserved by evidence-based peer-reviewed research. And in my conversations the last few years, I've learned from experts in the field on how difficult it is to conduct research on drug intake during pregnancy and postpartum because of the ethical concerns that it raises. And so as Melissa and I were talking yesterday, I was mentioning a conversation that I had with a cannabis nurse named Jessie Lynn Dolan. And she described to me that, yes, we can do environmental studies where people are ingesting a substance on their own without it being administered to them, but it's impossible to separate out the confounding factors like other chemicals that people ingest, or the environmental factors like air quality, and of course, stress. So what I've learned is that we cannot always rely on evidence-based research to look towards as a source of information. And so I'm very excited to be speaking to Melissa today, because she brings a real wealth of experience working with people during their pregnancy and postpartum, and also has done research on the topic. And also that she just brings so much heart to this work as well. And especially from her recent venture, which is her nonprofit that I'll talk about a little bit more as well. So let me properly introduce Melissa. Melissa Whippo, LCSW, is a psychedelic psychotherapist and the founder of Diva Collective, a nonprofit with fiscal sponsorship from MAPS that focuses on the intersection between women's health and psychedelics research, advocacy, and education. In her clinical work, Melissa combines Western psychology with ancient Eastern wisdom and plant medicine. In addition to completing a master's degree in social work from the University of Southern California in 2003, she has been a certified yoga instructor since 2004, and in 2022 completed a 4-year plant medicine apprenticeship with Francisca Santibanez. She has taught classes about perinatal mood and anxiety disorders at UCSF School of Medicine, Journey Clinical, and Embodied Life. And Melissa is a lead trainer in psychedelic-assisted psychotherapy, as well as a published author in both academic and popular journals. She lives in Berkeley, California with her husband, 4 children, and a Labradoodle named Appa. And I'm so happy to be talking to you, my friend, my colleague. Hello, Mom. My first question is about how you got into this work. Tell me about your work with postpartum parents. How did you get started in this? And then also talk to me about what changed when you began adding in your work with ketamine.
Thank you. First of all, thanks for having me. It's great to be here. This is a topic that's very close to my heart, and I'm happy to see so many people present who are interested in this topic and people that I recognize and close friends and colleagues. So thank you for the opportunity. I was working at UCSF. I was working in the obstetrics clinic for 10 years. I started in January 2011, and I had no idea what I was doing. I didn't know very much about maternal mental health. So I did all these trainings, and I was expected to have a wide breadth of knowledge to give to the resident doctors in the clinic and also to the patients. So it was really a crash course in perinatal mood and anxiety disorders assessment and treatment. And what I came to find out very quickly was how limited, as you said, Rebecca, the amount of peer-reviewed evidence-based information is about perinatal wellness. And also just not very many resources. And in 2011, people were starting to talk about it more. Certainly, we're talking about it a lot more now. I know Paige from the Motherhood Center. I know the Motherhood Center is someone from there is here today. And I think there have been a lot of wonderful organizations that have come out. But by the time I left that clinic at the end of 2020, I was feeling pretty burned out. But what kind of saved me along the way and opened up the aperture of what I think we can offer to parents and also families in the perinatal setting. So when I say perinatal, I mean pre-pregnancy, right? Preconception, conception, pregnancy, and also the postpartum period. And the American College of Obstetrics and Gynecology says that the postpartum period is the first year after birth. I think a lot of us see it can be a little more wiggly than that. It doesn't, a year comes after your baby turns 1, and it's not like if you have mood issues, suddenly they just poof, disappear. So I think it can be a lot longer than that, particularly if not treated. Sorry, I get excited and I go along. But then in 2018, I did a ketamine psychotherapy training, a ketamine assisted psychotherapy training. And I'm sitting there, I'm listening, I'm feeling really burned out from my work. And I had also just gotten back from my first trip to the Amazon. And so I'd been with plant medicines and amazing teachers and lineages. And I just asked, like, has anybody ever looked at using ketamine for postpartum depression. I'm hearing all this stuff about this ketamine being this amazing antidepressant. And Phil Wolfson was leading the training, and he said, let's do a study. And I didn't know him at all. So I just thought, okay, people say things like that, but okay. But then we did, then that study was published, I think in 21, but we started it in 2020. So it really, looking at the possibility of working within psychedelics, and I am by no means the first person to consider psychedelics for parents or postpartum. There's plenty of people who have done that already, particularly in non-scientific communities, indigenous communities and practices here in North America, but also in South America and other places. But this was the first time that it had occurred to me that we could do this work. And the results that I was seeing from the handful of people that I saw in the beginning for ketamine-assisted psychotherapy who were in the postpartum window, or even, give or take a little bit of time, maybe their baby was 2 or maybe 3, or they had a young child, it seemed really promising. And the results of the study were so, it was a very small sample size. It was only 4 people, but and they were all at different stages of still feeding their babies, nursing their babies with breast milk. And so the results were so overwhelmingly similar amongst the 4 people who volunteered for the study that we decided to go ahead and publish, because we were hopeful that publishing the information could have a positive impact on clinical recommendations that people make. And that's, Rebecca, the question that you get about safety is the same one that I get all the time. Is it, if I am nursing my baby, or if my partner is nursing the baby, what is the interaction between ketamine and breast milk? And there wasn't anything in the literature when we looked at that. And the result is that ketamine, a very small trace amount of medicine passes through the parent's milk. But after 12 hours, that's no longer happening. Ketamine, as we know, is very short in the system, has a very short half-life. And that was with the intramuscular administration. I think we can kind of estimate what that would be, but I think, back to the safety piece, people are reticent to make clinical recommendations about when it comes to babies ingesting substances. We have a lot of judgment about that in our society. So it's tricky, because even though we have this paper published now, I've heard a lot of clinicians say, well, we can't make a firm clinical recommendation, but here's what we know. We like to start with what we know. Mm-hmm. And so what we know is it seems like a viable option for new parents who are still nursing their babies or their children, however old.
Yeah. And that's, I'm sure for you get this question a lot of, asking for a specific recommendation. What is it safe is that question that comes up. And as the frustration ends up being, like, there's no exact answer to that question because there's just not very much information. But what's interesting in your study is that you could measure the amount of ketamine being passed through breast milk, and that just that gives people something to go off of.
Exactly. And I think when we look at a lot of the studies with ketamine are done with the IV route of administration or the intramuscular route of administration. And a lot of, when I talked with Journey Clinical's group about this topic, most people working with Journey Clinical are working with the sublingual tablets, the lozenges. And so because we think the absorption is between 20 to 30%, or some people say 20 to 40%, you can kind of guesstimate. It's not going to be exact, but I just usually tell people to err on the side of going lower than typical doses for this population. Because you can, just like other psychedelics, you can always add more, but starting with a slower experience seems to be prudent with this population, just because of the other factors that you mentioned also about sensitivity. Certainly sleep deprivation can be a factor in someone's sensitivity to the medicine, things like that.
Yeah, so let's just jump over to that topic that now that you mentioned it. So yesterday we were talking about postpartum bodies in general and the really pretty dramatic changes that bodies experience in those first days and weeks and months after delivery. So, how do you think about this when somebody's going through so many physical and hormonal changes? How do you take this into consideration when working with ketamine? I wonder if you can also just talk a little bit about how you work with this during an evaluation and also during the preparation phase.
Mhm. Yeah, so really great questions and important considerations. For the preparation, I think a really thorough intake, I mean, it's always important, but particularly with this population, because you really want to tease out a lot of folks postpartum are afraid to admit the severity of their symptoms because they're worried about someone's going to judge me, someone's going to call child protective services on me. So I think building that trusting relationship right away and saying, I'm not here. If you're having intrusive thoughts, I just ask people directly, are you having intrusive thoughts? And I try to normalize intrusive thoughts during this phase. It's really normal that you have this precious being, your child, who's 100% dependent on you, the parent. It's going to bring up what we call dependency conflicts. Whatever is unresolved within the parent around their own attachment and birth and early childhood experiences often can arise. This is not well documented in the literature, but a little bit it is. If you look at attachment theory, you look at people like Winnicott and others, even more modern people. But, I think it's really important to know what you're working with. If someone is dealing with a lot of scary thoughts, that might come up in the medicine space. So it's really important to do your thorough intake and to assess a little differently. When you're looking at somebody with a perinatal mood and anxiety disorder, it's not the same as somebody who has depression or anxiety or post-traumatic stress that are not related to this phase of life. That's why it's an important subcategory of people to talk about and focus on, because this group of people requires specialty care. I also really want to know, when we're doing preparation for the session, if we've decided this is a good idea. And also everybody I work with, because I'm a psychotherapist, they have to do a medical evaluation with the physician that I work with. So that's part of it too. We're lucky with ketamine. Most medicines interact pretty well with ketamine, and we know what people have to hold the day of. I think that it's also really important to set up for these sessions for people who have particularly young children to go home to after the session. What is the aftercare plan? And that if the person that you're working with is partnered, to involve their partner. What is their partner's attitudes, perceptions, feelings about the patient undergoing ketamine-assisted psychotherapy or other psychedelic work? Are they supportive? Big red flag if they're not. It's not a great setup for success if somebody is going home in a vulnerable state after the session and they have to jump right back into changing diapers, cooking dinner, doing laundry, all the things. It's a recipe for disaster. So I'm really honest with people about that. And if they're describing to me a situation in which it doesn't feel like a good setup, I usually offer to people that we wait until that aligns, or we see what we can work on, or I offer to talk to the partner. I feel like this population of people really needs wraparound support care. So really thorough, thoughtful preparation, assessing for external and internal safety, right? Because a lot of this stuff, and Groff talks about it in the way of the psychonaut when he talks about the birth matrices, but the perinatal time in a person's life can bring up a lot of old, unconscious, potentially pre-verbal material. And so we understand that the medicine spaces can help us access some of this material. So we want to prepare our people thoroughly to meet some of this material if that is potentially going to happen. So there's the kind of emotional, internal safety piece. There's the external, logistical plan piece and the follow-up piece. We all understand that that window of neuroplasticity after the medicine session is really important. So to try to schedule a follow-up session within 24 to 48 hours. That if that can't happen, I try to at least check in with people, a brief phone call or sending messages. Some of the platforms that we use have secure message sending. I use Osmind. So it's a good way to message with people that's more HIPAA compliant. Yeah. Have I left anything out? I think that's
so good. Yeah, so good. And you know, I think you bring up this very specific time of life. And I taught you a new word yesterday, which is matrescence, right? Like adolescence, but for matre. So, you know, we talked a little bit about, and you're speaking about now this huge transition. We might call it the maidenhood to motherhood transition, and all of the psychological material that sort of rushes to the surface as this massive life change happens. So you touched on this a bit, but I wonder if you could talk about it a little bit more. The pre-verbal trauma and also birth trauma that you use ketamine to work with, and how is that useful in accessing those traumatic material, those types of traumatic material?
I mean, some people feel like it's the only way to be able to access some of this material because it's so buried and it's pre-verbal. I mean, Groff was writing in 1975 about this, and I don't know if he's correct. He says that he was the first person to use the word perinatal in connection with consciousness, but you know, Ina May Gaskin also was writing spiritual midwifery at the same time. So I think there was somebody else talking about perinatal consciousness. But you know, what I appreciate about what he says in the way of the psychonaut about birth matrices and kind of this notion that people have stored unconscious birth trauma inside of them that can present problems later in adulthood. And it's really hard as adults to we like to figure things out and trace the origins of things in psychology and neuroscience and psychiatry. And so we don't have a story about what happened so for example, I was a forceps baby, and in my ketamine training, and Groff writes about this, there's an essay by him in the ketamine papers where he talks about it, certain dosages of IM ketamine, I think he said 80 milligrams and above, which is what I had in the training, people may revisit their birth and have potentially a healing of their own birth trauma. So not only did I experience that, my first time experiencing IM ketamine at that dose, then I was curious about it because I had this kind of textbook experience. And so I read a lot more about it. And he talks about having subsequent experiences. So I, you know, in that experience was able to have a big healing with my mother. And then there were subsequent experiences that were frightening and really line up with what he talks about, even to the imagery that people can experience. So I, you know, have a lot of support and a lot of knowledge and experience. So even though some of those journeys were challenging or had challenging bits, I felt like it really afforded me really good material for my own personal work. And what's interesting is that, you know, Rebecca and I were talking about this yesterday. There is a way in which, you know, those of us who have truly suffered, and I do think, I mean, birth trauma is a legitimate suffering that gets stored in our cellular memory, but that we don't talk about. You know, I don't introduce myself by saying, I'm Melissa, I was a forceps baby, I have this birth trauma. But it was more so also what happened with my mother, because I understand that my mother probably was having a panic attack also when I was born. It's stressful. Traumatic births are stressful for the mother and for the baby. So if you have an adult in your practice, it's good to know that if they had a traumatic birth experience themselves, I always ask people that I'm working with, because that may come up. I've seen it come up in training experiences as well. And then you can help people through that if you know what you're dealing with, or help them make sense of it afterward. In the internal family systems language, Dick Schwartz talks about this opportunity for what he calls spontaneous unburdening in psychedelics. And I really felt like I had that with my first ketamine experience. And then what I saw with the parents that I worked with, primarily female identified mothers with young children, they felt like for their birth trauma, the ketamine space, like we understand about ketamine, it provides this time out from the typical and usual way we think about things. So unfortunately, what I see a lot for folks who have birth trauma is blame and shame. They blame themselves that they had a C-section delivery instead of like some, supernatural home birth. Even the word natural, I think, carries a lot of judgment in it. And I really just like to point out to everybody that any way you give birth is natural and valid and important. But a lot of folks carry shame if the birth didn't go the way that they expected it to, or wanted it to, or needed it to. And so there can be trauma wrapped up in that as well. And I see that the ketamine experience really helps people reframe the story of their birth, which can be really empowering. And they're able to have a different view on the other side of the ketamine experience that can be really helpful. Another piece is that, a lot of new parents have difficulty with attaching to their baby. Sometimes we don't talk about this enough because, again, there's a lot of shame. A lot of mothers would say to me, I just didn't fall instantly in love with my baby. There's something wrong with me. I find it actually really challenging. I don't like my baby. I don't think my baby's cute. And if we do a little bit of work around, their earliest experiences or relationship with their own parents, we can often see where this is coming from. And sometimes there's organic things coming up that maybe the baby and the parent are just not a match with temperament. It happens. And again, the ketamine experience helps people soften some of the judgment and the shame around it and get underneath and have maybe memories come to them from their own childhood experiences that flood them with compassion. I remember one mother said that she was able to realize like what a good baby she had been, actually, that she was a lovely little baby. And she felt like she had the experience in her ketamine journey. And it was it was like 1.5 tablets. It was a very low dose of medicine. She experienced loving herself, holding herself lovingly as a baby. And she could really see that parallel process. Oh, wow, not only do I get to mother my kids the way that I want to mother them, I'm mothering myself the way that I wanted and needed to be mothered and that my mother couldn't do for me. And she could have a real transformation around that spaciousness and lightness that really helped her move through some of the anxiety and depression that she was experiencing. And I think her baby was around 9 months old at that time, so very much in the postpartum window, and her first child was around 3. And she only did 2 ketamine sessions. She really didn't need a lot of medicine work. I find that this population, unless we're talking about very severe, somebody who's in active suicidality or potentially psychosis, then there's more intervention that needs to be involved. But for people who have, anywhere in the perinatal mood and anxiety spectrum, birth trauma, depression, anxiety, things like that, I think that ketamine can be a really helpful option.
Mm-hmm. Yeah, I mean, this is so rich what you're saying right now, and it really touches me to think about the way that a new parent goes down a different path than the one that was handed to them, and that's a way that they reparent themselves. We were talking about that yesterday.
Mm-hmm.
So sweet and rewarding to be with a patient as they're going through that process. You're talking a lot about some of these really valuable and specific questions that I can imagine coming up in preparation as well about, what is the birth story that you're aware of, and knowing that history before you get in the room with someone could really help you understand, okay, this might be what's happening in the room, and during that meaning making integration process, being able to help somebody put those pieces together. So that's really really important. And another thing we talked about yesterday is just the challenge of a postpartum person in general being pulled in so many different directions with a newborn. So I would love for you to talk a little bit about your work in home with patients. Anything special that you do as part of preparation to look at the transference and countertransference that could be heightened in an in-home environment, and why that might be potentially more desirable for someone in this postpartum state?
It is 100% more desirable for the person who is postpartum, for them to have the ease of being in their own home. I mean, you can subtract the time it takes to get to the office and the time it takes to get back. It really, it lessens the burden on the parent when we come to them. And when we think about early medicine, the practitioners were always visiting the people who were receiving the services. I struggle also with language. I struggle with the word patient because I'm not a doctor, and I struggle with the word client because I'm not trying to sell anybody anything. So I like to say the people that I work with, but it can get a little confusing. So, the people who are asking for our services and receiving our support and our help, it's a beautiful act of vulnerability for them to invite us into their homes. And I think it's so important for us to tread lightly and also to do, again, an extremely thorough assessment and to talk about in advance. We can't possibly mitigate everything, when it comes to transference and countertransference, but I think it's important to talk about as much of it as we can in advance. How is it going to be for you to have me in your home? What do you imagine? What are and they might, considering their own relationships with their partners or their parents, maybe they have a critical parent, now a grandparent who comes over to their house and walks in and says, "This is a mess, and what are you doing?" And maybe they have a smothering grandparent in their lives, or maybe they have a partner who, they're struggling with the work-life balance and home things. And so, reassuring your people, I'm not coming to your home to judge you, I'm coming to support you. And making sure that they have a space that is safe, where they can remain, and that has access to a bathroom, of course. Who else is going to be home? If they have young children, obviously there needs to be somebody else there to provide childcare, because the person receiving the medicine cannot provide childcare. We cannot provide childcare while we're there. And I do often have a different informed consent that people sign and liability for coming into somebody's home. I think we just have to be really careful. And typically, when I do a home visit, the route of administration is the oral. So they're using their prescription that they received from their physician, or the physician that I work with, John Gillian in Oakland. He's wonderful. So they have their prescription from Dr. Gillian. They're using their medicine. Usually we've decided upon the dose beforehand. We've talked about it with Dr. Gillian, with the patient. We've done our prep sessions. And then being there, I think talking about what it's going to be like for them after the session. So talking about what it's going to be like for them to, have you in their home, also what it's going to be like during the session and afterward. And I have to say that I haven't done that many home visits, but in all of them, I've never had a problem, never had anything go sideways. It actually seems to set up and support a really nice integration also for the folks working with the medicine, because they have the spaciousness. And if we've set things up in a good way, then they can just ease into their integration in a really supported and nurturing way. I mean, I would hope that we could do more of that.
Yes, right. It's such a wonderful idea to, make things so much easier for new parents. And you're reminding me of a conversation that I had with a woman named Marlena Robbins. She works at Chacruna, and we talked about how do you prepare for a psychedelic journey. And she said, you do your dishes, you do your laundry, you fold your laundry, you put it away, right? And like thinking about how an in-home visit, those sorts of logistics might come up in your preparation so that this person can just be easeful and rest and relax after that journey in their own home environment, and how seamless and sweet that must be. Um, so, I want to just move for a few minutes into a question about research. So I talked in the beginning, and you have gone through this process of getting your research through an IRB. And you have this initiative, the Diva Collective, which is focused on women's health and psychedelics. I want to just ask you about, what do you think it will take, if it's possible, for research to change when it comes to this topic? And if you could just tell us a little bit more about Diva Collective.
I would love to. So, having been at an academic medical institution for a long time, so before I was in the OB clinic, I started at UCSF in 2007 in the pediatric hospital. So, still working with moms, but parents whose children who needed liver transplant. It was really intense. And even though I was there for a long time and I had many opportunities to teach and run a support group, my colleague and good friend Julie is on this call right now. We ran a support group called the Afterglow for many years together for new parents. Really wonderful. But I didn't have any opportunities to do any studies while I was there. So when Phil invited me to be an author on this paper, the lactation paper, it was a wonderful opportunity for me. And what has happened in academic research is kind of nice, and hopefully, we have to go, from my view, we have to go more in this direction where we're looking at these more environmental observational studies. There's so little information, as we both mentioned, about perinatal wellness, but also just about women's health in general. So Diva Collective, and I'm representing with my Diva Collective scarf today. You too can have this scarf if you like. The Deva is a Sanskrit word, and I'm, as Rebecca mentioned in the introduction, I've been a yoga teacher as long as I've been a psychotherapist, and I spent a long time in my 20s learning Sanskrit. And Deva is a Sanskrit word that is basically like, it means shining one, but it's a force of nature. And there's something about, I knew that I wanted the word collective to be part of it, because I feel like we're in this really pivotal time where we're moving out of this more capitalistic, patriarchal, scarcity, competition model. And all of the evidence-based information in Western medicine is based on the white male body. That's partly why there's so little information on women's health. And it's also not a big moneymaker, unless you look at a drug that came out a couple of years ago called brexanolone, which supposedly is going to be a cure-all for postpartum depression. It costs $30,000. You have to stop breastfeeding your baby to receive it, and you have to be admitted to the hospital for several days. It's an infusion medicine. I think the numbers are pretty good in terms of outcome of postpartum depression, so we can't argue with that, but all the other parts I have issue with. So based on all these things and people encouraging me from MAPS, we applied for fiscal sponsorship, and we started this nonprofit to focus on women's health and psychedelics research and education and advocacy. So we know, any of us who are working in psychedelics, I hope, have some education around, the original people's stewarding and working with these sacred medicines. Certainly many of my ancestors in Ireland and Germany were working with psychedelic mushrooms and other mystical ways of being, but we are receiving so much wisdom from our plant teachers and wisdom keepers and indigenous stewards from the South and also from here in North America. So I hope that we're all educating ourselves about where these medicines come from. None of their knowledge is contained in the evidence-based canon of medical information. So we're hoping little by little that these studies can change that. So our first study, we have an IRB, it's on hold because we're working with a Schedule 1 substance. So we have to change the language. We're working with San Pedro, which is a cactus medicine. And we're working with bodies who are in perimenopause, which spans a whole, could span a decade for some of us. microdosing this medicine. What we have come up against is that we cannot be seen as encouraging people to start a microdosing practice with a Schedule 1 substance. So we're just, as Rebecca mentioned before, this will be an environmental observational study. We just happen to find people who are already doing this, which they're out there for sure, and gathering that information that people are generous enough to share. We hope to do more work with the perinatal population as well, but we just knowing what I know from doing the lactation study, it's very challenging to get studies approved for the perinatal population. So we decided to focus on perimenopause because it's also a really underserved aspect of women's health. And that we chose San Pedro to work with because it doesn't seem to have issues of exploitation and overuse as some other medicines have at this time. At least where I live in Berkeley, California, it's pretty much in everybody's front yard.
Yes.
So,
Beautiful.
as Michael Pollan said.
Yes. That's so exciting that you have that initiative and that there's work happening around this perimenopausal phase, which I'm well aware that there's such a dearth of information and so much conflicting information about that phase of life. So that's really exciting to be looking at the interaction with psychedelics. I want to just jump over to the Q&A for a few minutes. So please, just a reminder, go ahead, pop those questions in the Q&A, and we have some here already. I want to just make mention of this, and Annette, if you want to just clarify this question a little bit, that would be great. But the question is about multicultural impacts, and as you were speaking just now about indigenous lineages who have used these medicines, for time immemorial, it made me think a little bit about the use of the abuses that have taken place in the prenatal, pregnancy, postnatal, gynecological space in general, particularly against Black women who have been disproportionately harmed by this. So it just made me think a little bit about that layer in an evaluation or preparation of thinking through, like, what are the impacts for someone from a BIPOC community of thinking about using this intervention, which is not, broadly done or broadly utilized, and thinking about how that lineage of abuse would play into their comfort level with using these medicines for postpartum depression, things like that. So I don't know if you want to add anything to that, or Annette, if you want to pop any additional questions into the Q&A.
Yes. Yeah, and I'm looking at what she's saying in the chat too. The research in multiple races and studies. Yes, and actually that was important to us, even though we only had 4 people. We had one woman of Latina descent, one woman of Han Chinese descent, another woman of mixed race, mixed Latino and Caucasian descent, and one Caucasian woman. So my experience has been, working with people of color, that there is a kind of institutional generalized suspicion about medicines in general, which I fully respect. Again, just more care and attention is needed when talking about these things so that nobody feels like they're being pressured or that they're being experimented on. I think that's why it's also really important to work with people of color about these things and to educate ourselves and to not make assumptions or generalizations. All bodies are different. And that's why I think, there's actually something in the literature about Black women experiencing perimenopause earlier, younger than other races of women. And so a lot of times they are dismissed by their physicians when they go in and complain, at age 34 or something, that they're having perimenopause symptoms. But it's actually true that I think it's something like 26% of Black women experience these symptoms earlier than other women. So it's really important to take racial and cultural considerations into context, for sure.
Yeah. Thanks for that. So this is a quick question about whether the paper that you published about ketamine and breastfeeding did it measure ketamine or, the amount of ketamine or metabolites in baby serum? And she says, thinking it's likely even lower than in the breast milk, given low oral bioavailability.
So we used the intramuscular method, so which is believed to be, I think, between 95 and 97%. And so we did doses, we did two different doses. Like we did 0.5 milligrams per kilogram and then 1 milligram per kilogram. And we did measure the active and inactive metabolites of ketamine. It's all in the paper. You can take a look, but it's true. I mean, I think there were fewer of the metabolites that passed through. But it's all there. It's all in there. Because the lab at UCSF at San Francisco General Hospital analyzed our data, and the woman who runs the lab was also pumping breast milk at work. So she very graciously offered her milk as a control.
Oh,
For
lucky. That's fortuitous. Yeah, it's great.
It's the one thing that's nice about doing this work is people find it fascinating, whether they agree with it, don't agree with it, they think it's interesting. So they're willing to
Yeah, that's right. That's right.
At least in the Bay Area.
Yeah, that's right. That's true too. That's fortuitous. This question from Lissa is asking about in-home work and also about accessibility. So she's saying she can see how in-home work would be ideal, but how do you make it both safe for the provider and also thinking about adding a second provider to, increase the safety for the provider and also affordable for the family? Any thoughts about that?
Yeah, I think, it's wonderful to be able to work with two providers, to work dyadically in psychedelics for many, many reasons. And I think the safety piece for the provider comes with a thorough assessment. Who lives in your home? Who's going to be home? And again, back to the attitudes and support of the people in the person's life who's receiving the treatment. How long are you going to be in the home? What's the home like? And I think, a lot of times it's less affordable for people to have two providers. I have done a home visit when the physician came as well, and offered an injection because you can, it is legal and reasonable for physicians to be able to carry a small amount of medicine. And the way that we are having to do things in California right now with liquid anyway, all of the medicine is sent to the patient's house anyway. So kind of makes the home visit a little easier. But primarily working with oral ketamine and their prescription has been the way that I have done it. I think making this work affordable and accessible to people is really important. So that's part of the assessment, and the treatment plan as well. So usually the dyadic sessions cost more because of both of two providers being there. So maybe you could have a second provider there for part of the time. But again, I wouldn't do a home visit for someone that I didn't feel 110% comfortable doing a home visit. I've been a social worker for over 20 years. I've done plenty of home visits without medicine. I've been into many places where I didn't necessarily feel safe, and I don't do that anymore. So I think, we learn.
Yeah.
We learn a lot along the way.
Yeah. And
I think,
go ahead. Yeah. Sorry.
Well, just with all consciousness altering medicine, we want to feel 100% safe. If there's any inclination that it's not the right thing for that person and us at the particular time, then we don't do it. Everything can be revisited. There's no rush to do anything. So I tell people that all the time because it's a little bit of a red flag for me when people come in with a lot of urgency and a lot of expectation on the experience. I understand where they're coming from, they're suffering. But we have to be careful as providers not to get sucked into that urgency, right? Because if it's a safety issue, then we need to respond in an urgent way. But I mean urgency with the way that the medicine work unfolds. I think there's a real care and attention that is required that, requires a lot of careful evaluation, particularly for the home visit situation.
Yes. And in terms of accessibility, one additional consideration that we were talking about yesterday, and a reason that ketamine can tend to be more favorable as an intervention is because you don't use it that often, right? It's not a daily intervention.
Exactly.
So when we think about these sort of economics of, addressing something more in depth, more thoroughly, addressing some underlying causes versus, being on a medication and receiving therapy for years and years, that maybe becomes part of the calculation. And another thing that I just wanted to bring forward that I thought was such a good point that you mentioned yesterday, because people's time is so limited in this postpartum phase because they're so stretched, there's a
Yes.
lot of motivation to
Yes.
extract as much as possible from these sessions, to work as hard as they can to get something from the work that they do. And so there might be a tendency to just like dive real deep really quick. And so
Really
that
quick.
becomes sort of part of the economics as well. And that being said, not to discount the fact that this work is incredibly expensive and we absolutely do not have infrastructure to support broader access to this at this juncture, which is something that we all, is a problem for all of us. Let me
It's why the research is so important, right? The
yeah,
more evidence-based information we have that supports the work, the more a lot of us believe that the access will widen, and things will be more available when they're more widely recognized as being legitimate.
yes. So I'm gonna just sort of arbitrarily pluck out this last question. We did talk a little bit about IV versus IM.
Mhm.
I know that comes a lot down to accessibility of your prescriber. Who is your prescriber? How do they prescribe the medicine? In what form? Economics are part of this discussion too, because for
Mhm.
people who are not prescribers, there needs to be another person in the room to administer an IV or an IM.
Right.
So this person, Julissa, was asking about the lozenge. And I just wanted to bring forward what you
Oh
said
yeah.
already about starting low and gently with a postpartum
Yes.
body that is experiencing a tremendous amount of hormonal changes, and
Yes.
lozenge potentially actually being more favorable in that regard.
In a lot of ways, yes, particularly because of the gradual come on of the medicine with the lozenge. And this was what, I talked about with Journey Clinical because they only use the lozenge model. I think for some folks, even starting them with a half of a tablet, for some that, maybe are more psychedelically informed or experienced from earlier times, starting out with one, the way that I was taught with the oral administration was that we always start with one, just one tablet, because we can always add more. And they have to hold it in their mouths for 15 minutes. So it's an opportunity actually to really work with the person receiving the medicine, to maybe do some guided breath work or meditation work while they're holding the lozenge in their mouth. And then you can check in with them about the strength of the medicine and how it's going, and you can always add on. And I think these are things that are really good to talk about beforehand as well. Um, and I wanted to say something about Spravato because we haven't mentioned that a lot. And I don't work with Spravato. The doctor I work with doesn't really work with it either. Breastfeeding patients are not allowed, like physicians are not allowed to prescribe Spravato to their breastfeeding patients. This is what I've been told by a perinatal psychiatrist here in California, because Spravato has to be administered in office. And I think people in their reproductive phase, I don't know if they have to take a pregnancy test, but if they are lactating at all, they're not allowed to do this Spravato protocol. So this, our study was done with just the generic Ketalar, the liquid ketamine that people get for IV and intramuscular usage. But I think it's applicable to the lozenge work as well. And that is one way that it can be more affordable. If somebody has a supervised session with you or more than one, and they feel comfortable doing the lozenge work at home, and then you're doing your regular therapy sessions for integration and to check in, that's something that can work for people to make it a little more affordable as well, if they feel comfortable having that session at home.
That's a great suggestion. Yeah. So I noticed that we are at time, although I feel like I could go on and on with you for so long. Before we sign off, I just want to, first of all, I want to say thank you so much. I feel so expanded and nourished by all of our conversations, and I feel lucky to learn from you and your wisdom and experience on this topic. And thank you so much for taking the time for this. And before we wrap, I just want to make mention on December 13th, Fluence will be hosting a webinar on MDMA-assisted psychotherapy with Rick Dablin. And you can sign up on the Fluence website for that. Again, you'll all receive a recording of this so you can reference back. Thank you so much to everyone for your questions and for your attendance, and great to have you with us.
Thank you.